We're trying to help these patients live longer, but we want them to be able to live better.
I wanted to talk a little bit about, your clinical practices. We all have experience now with Enhertu. Tell me, do you have patients on it for a long time? How do they tolerate it? Tell me your experience.
So I think in both settings, whether it's HER2 positive or HER2 low ER positive, in other settings we've used Enhertu. And I think there's probably three things that come to mind for toxicities for me. One of them is going to be that early nausea, vomiting that can be a very real issue, right? It's a highly emetogenic protocol. I think having a 3-drug regimen, at least 4 to prophylax patients, is important. I think olanzapine is quite helpful in my practice to also manage that particular nausea, but I also don't find it to be rate limiting for the long haul. I feel that if we get really good control of that issue up front, that we can really set the stage for success. Issue number 2 is fatigue. I think it's a real issue. We know that it's still a cytotoxic payload at the end of the day. And so when we've gotten the best type of response and people are on long-term in HER2, it's important to consider the aspects of their life into their treatment. So taking a trip, events, it may not be that you'll give them dosing every 3 weeks, at least for the long haul, right? And then cytopenias, neutropenia could be another thing. Obviously, you spoke on alopecia. Alopecia seems to be a little different than traditional cytotoxic chemotherapy. It's much slower. I don't know your collective experiences with cold capping, but I have certainly had those patients who have been very motivated to use cold capping with Enhertu as well.
I did want to talk about, one strategy I've used in clinic sometimes is a dose reduction. Were there dose reductions on the trial? Is that a good strategy for keeping patients on drug?
Mm-hmm. We have had experience doing that, and those patients that I have, going on 2+ years of T-DXd certainly get to a point where, particularly if they've achieved a complete response and, they're doing really well, we want to look for opportunities to improve their quality of life. Certainly we're trying to help these patients live longer, but we want them to be able to live better. So making sure we're doing good internal medicine, checking thyroid functions, checking vitamin D levels, doing all the things we can to help maximize their quality of life in terms of their energy level. But using dose reductions is something that we certainly do early on. I think in the DESTINY-Breast9 trial, it was a little more than a third of the patients that had a dose reduction. So we can feel comfortable telling our patients this, about a third of the patients in the trial had a dose reduction and they still had that significant efficacy. So I think if you dose reduce based on your patient's symptoms, you should feel quite comfortable with that.
Yeah, and I think that's something doctors should realize. And I've certainly seen in my practice in terms of the fatigue, it often does respond to that dose reduction sometimes. So definitely something important to put out there. And also so patients don't feel disappointed if they have to lower dose, because patients want to, of course, get the best treatment they can.